your topic is cystic diseases of kidney, very important topic for theory examination, and as well long question as well as short notes can be asked from this topic. Your kidney class, how many classes have also already taken in kidney? One only, by two classes. Okay, this is the third classes, and we'll learn today the various ranges of cystic diseases of kidney. Today I am down with common cough and cold, so don't shout much, don't make much noise, okay? So, starting with what will our objective or topics today: definition of cystic diseases of kidney, the pathophysiology, the classification, and the diseases in detail. Okay? Now, what is a cyst? Cyst is a saccular like structure or a fluid filled sac that grows on the surface of or within the kidney, whether the position is cortex or the position in medulla. Okay, so it is a fluid filled sac present whether in the outer surface or in the inner surface of the kidney. Generally arises from the renal tubules. Okay, so this is a schematic diagram of a sac. This is a cyst or sac lined by tubular epithelial cells, dilatation of the tubule, and the epithelial cells lining the basement membrane secrete the fluid that tends to accumulate within the sac or the cyst, and the cyst or the saccule lies in the matrix. Okay, so as well as the cyst is small sized and the secretion is less than that of resorption of the fluid, then the cyst won't large in size. But whenever there is excessive secretion and it overcomes the absorption or resorption capacity of the kidney, then the cyst enlarges in size and exerts its pressure effect on kidney parenchyma and various diseases occur. So, here are schematic diagrams of various cystic diseases of kidney. This is normal kidney, cortex, medullary pyramids, and pelvic calyceum system. There is no cyst. This is simple cyst. Simple cortical cyst arises from the cortex, often found incidentally. This is adult recessive polycystic diseases of kidney. Multiple kidney is comprised of multiple medullary cysts near the pelvic calyceal system. This is dominant polycystic kidney. The entire kidney is replaced by innumerous large and small cysts. Okay, but this is hydronephrosis. This is not cyst. What is hydronephrosis? That is the dilatation of the pelvic calyceal system due to block in the outflow. Okay, whether it is an ureteral level, whether it is a vesical level, whether it is a urethral level, but there is obstruction of the outflow and the back pressure results that expansion of the pelvic calyceal system, and this condition is known as hydronephrosis. This is dysplastic kidney with minimal identifiable renal tissue. Medullary sponge kidney, we will tell every diseases in detail in later slides. Yeah. Medullary uremic kidney and dialysis cystic kidney, all will be told in details in later slides. Okay. Now, the most important entity, the most important, often favorite topic to come in theory examination as long question: adult dominant polycystic kidney disease, ADPKD. ADPKD. So, It is the most common, most prevalent cystic diseases of kidney, and it generally occurs in the adulthood, or the diagnosis is done in the adulthood with a dominant type of inheritance pattern. Okay, and so it is called as adult dominant polycystic kidney disease, ADPKD. So its prevalence is 1 to 400 to 1 to 1000, but estimated half cases clinically silent and undiagnosed. So half of the case are undiagnosed due to lack of clinical symptoms. If anybody don't experience any symptoms of urinary retention or urinary tract infection or symptoms from renal failure, he or she may be undiagnosed throughout of his life, but there is a prevalent family history in his germline. Okay, so adult dominant polycystic kidney disease or autosomal dominant polycystic kidney disease. Okay, autosomal dominant polycystic kidney disease. Commonest defect is PKD1 gene on chromosome 16 and PKD2 on chromosome 4. So autosomal dominant polycystic kidney disease is contributed to the genetic defect of two genes, PKD1 gene, polycystic kidney disease 1 gene that resides on chromosome number 16, and PKD2 gene that resides on the chromosome number 4. Okay, more common is chromosome number 16, that is PKD1 gene. Okay, cyst or ESRD, that means end stage renal disease. ESRD occur later in PKD2 versus PKD1. So mean age of end stage renal disease is 74 in PKD2 or polycystic kidney disease 2 and 54 years in PKD1. That is not so important, but what you have to remember that autosomal dominant polycystic kidney disease is contributed due to the genetic defect of two genes, more commonly PKD1 on chromosome 16 and less commonly by PKD2 on chromosome 4. Okay. Now what is this gene encodes? This gene encodes a protein named as polycystin 1 and polycystin 2. So there is a gene, so invariably there is expression of a protein. So what is the name of the protein? That is polycystin 1 and polycystin 2. What is the action of this protein? This is a cell-cell interaction, activates JAK-STAT pathway causing cell cycle arrest. So polycystin 1 is a cell cycle regulator protein, activates the JAK-STAT mechanism that is causing the cell cycle arrest. So the proliferation won't occur and the formation of the cyst occur. Polycystin 2 involves calcium signaling via G protein. So polycystin 2 is G protein coupled calcium channel receptor. Okay, so polycystin 1 gene is JAK-STAT pathway, activating JAK-STAT pathway, that is a cell cycle protein, and polycystin 2 involves calcium signaling via G proteins, and both this polycystin 1 and polycystin 2 are expressed in renal tubular epithelium as well as hepatic bile duct and pancreatic duct. So wherever the organs in our body that have duct, that have tubular epithelium may be expressed by polycystin 1 and polycystin 2 gene. Okay, clear? Next, gross picture of autosomal dominant polycystic kidney disease. You can see this is the two kidneys. Okay, bilateral nephrectomy patient, whether the patient may be transplanted by new kidneys. Okay, can you see the cyst? Innumerous number of cyst of various sizes. Cyst. Okay, this is the outer surface is laden with innumerous number of cyst of variable sizes. Okay, everybody can see the picture. Hey, ওখানে দেখতে পাচ্ছিস কি দেখছিস তোরা নিচে? আসছি তোদের কাছে দাঁড়া। So diagnosis is depends upon the screening. So from the name it is seen that autosomal dominant polycystic kidney disease. So the defect of the gene or the cyst in kidney invariably present in parents of the patient. Okay, I told you earlier this is a dominance type of inheritance. Okay, so diagnosis generally relies on imaging, usually ultrasonography. Sometimes genetic testing is required for definitive diagnosis whether the PKD1 gene and PKD2 gene are knocked out or not. Three main criteria: family history, number and types of the cyst, and age of the patient. So only the family history is not important, the age of the patient and the number of cysts in both kidneys are also important to make a diagnosis of autosomal dominant polycystic kidney disease. So screening is not recommended before age 18 because of psychological burden. If the patient is not symptomatic, so no need to screen the patient in spite of having a definite autosomal dominant polycystic kidney disease of the parents. Okay, because of the psychological pressure, he or she may be affected by the psychological burden from routine screening. So family history positive but genotype unknown. So there are three age group: age 15 to 39, 40 to 60 and age 60 or more. From age 15 to 39 you require 3 or more cysts in both the kidneys. Okay, I told you earlier, family history, number of cysts and age is three criteria to arrive at diagnosis of autosomal dominant polycystic kidney disease. So there are three stratification of age groups. One is 15 to 39, 40 to 60 and 60 or more. So for the age group 15 to 39, the number of cysts for requiring the diagnosis of autosomal dominant polycystic kidney disease is 3 or more cysts in both the kidneys. Okay, unilateral or bilateral cysts, but the number of cysts must be 3 or more. And age 40 to 60, 2 or more cysts in each kidney, and age 60 or more, 4 or more cysts in each kidney. So the number changes, the number of cysts changes to diagnose the case is variable. Okay, now alternate imaging method is CT scan or MRI, but more sensitive is ultrasonography. Okay, more sensitive and may pick up the smaller cyst in CT MRI, but CT MRI due to CT scan have radiation hazard, so not recommended for routine screening procedure. No studies have examined the diagnostic criteria with these modalities. So in diagnostic criteria, these modalities have not been picked due to radiation hazard. And current opinion is that if no cyst detected in kidney or liver by age 20 may exclude disease, if result inconclusive, genetic testing should be pursued. So at the age of 20, if there is no cyst in both the kidneys detectable, it may exclude the disease. But if results are inconclusive, genetic testing should be done to know the defect of polycystin 1 and polycystin 2, these two genes. Okay, absence of family history. What about the patient who meet criteria but have no family history of the disease? 25% of these patients have an undiagnosed relative, can screen family, and 5% represent new mutations. So it may be occurred that the family history may be unnoticed due to absence of screening. Okay, the parents may refuse screening. আমার symptom নেই, আমি কেন screen করব ভাই পয়সা খরচ করে? তো screening may be absent, so diagnosis may be must. If in absence of family history, there is no definitive criteria, diagnosis is suspected. If more than 10 cysts in each kidney, other cystic disease should be considered. So with family history, known positive family history, the number of cysts varies between 2 to 3 to 4. But absence of family history, if the parents are or relatives are undiagnosed or have not been screened, then the number of cysts to diagnose the autosomal dominant polycystic kidney disease, the number of cysts is 10 or more cysts in both the kidneys. Okay, next, genetic testing, microsatellite instability, linkage analysis. for the status of chromosome 16 and chromosome 4, the gene status PKD1 and PKD2 requires at least 4 diagnosed family members, therefore useful in less than half of the cases. So these are the criteria. Okay. Clinical course. What are the symptoms that may patient come to you? Flank pain, most common, flank pain, and the pain refers from loin to groin. Okay. The pain arises from the kidney, has a unique character of referral. That is, the pain originates from the loin and it comes down angularly to the groin. Okay, it may be occur from both sides. So, flank pain, hematuria, proteinuria, calculus or stone, urinary tract infection, hypertension, renal insufficiency. So, these are the spectrum of clinical symptoms, but most common is flank pain. Renal function intact until 4th decade. So, this is the main reason why the autosomal dominant polycystic kidney disease is undiagnosed at the age of 40 to 50 due to absence of any clinical symptom. The latest clinical symptoms arise to make patient cautious at least 4th decade. Okay, and declines at a rate of 4 to 6 ml per minute per year. And this rate of decline of kidney function is faster with PKD1 gene and slower in PKD2 gene. Everybody clear? What are the extrarenal manifestation? I told you that these polycystin 1 and polycystin 2 genes, these 2 genes are evident in renal tubular epithelium as well as any organ that have tubule, kidney, pancreatic duct, and also cerebral aneurysm or the vasculature of the cranial architecture. Okay, so cerebral aneurysm is the most common extrarenal manifestation of autosomal dominant polycystic kidney disease. 4 to 10% based on age, family history of aneurysm or SAH. What does it mean? Subarachnoid hemorrhage. Okay, rupture occurs with larger aneurysms and with poorly controlled hypertension. So, maybe a cerebral aneurysm, that is the saccular dilatation of the cerebral arteries, or may be undiagnosed if the patient have no other comorbidity. But if the hypertension or any comorbidity, and that is the status of uncontrolled hypertension and risk factor of the rupture of aneurysm, like smoking, like hyperlipidemia, like diabetes mellitus, then if rupture occur of cerebral aneurysm, then subarachnoid hemorrhage occur. The hemorrhage that is causing intense headache of the patient with diplopia, with loss of vision. Okay, subarachnoid hemorrhage presents an acute severe headache. CT scan might miss small bleed. Lumbar puncture should be done 6 to 12 hours later. So, CT scan may miss the small if the bleeding amount is small. So, this is, what is this? Angiogram, cerebral angiogram. Okay. So, you can see that is saccular dilatation of the cerebral artery. Okay. So, it may be undiagnosed if there is no comorbidity, but if there is uncontrolled hypertension or predisposition of other risk factor, then it may rupture and cause acute subarachnoid hemorrhage or severe headache. What are the other extrarenal manifestation? Hepatic cyst. Okay, prevalence is 80% in patients aged 15 to 45. So, hepatic cyst is also there. Massive cysts occur almost exclusively in ovum. Multiple pregnancy accelerates growth, maybe the effect of estrogen. Most asymptomatic and some require pain controls or antibiotics. So, what are the extrarenal manifestation? First extrarenal manifestation is cerebral aneurysm and next is hepatic cyst. What are the prevalence? 80% at the age of 15 to 20, 35, 45. Okay. So, hepatic duct cyst is another important extrarenal manifestation. The CT scan. এটা কি? এটা CT scan এর প্লেট, এটা দেখ কি? এটা হচ্ছে ভার্টিব্রা। এই দেখ লিভার। দেখেছিস? বুঝতে পেরেছিস কত cyst? So multiple hepatic duct cyst, these are important extrarenal manifestation of autosomal dominant polycystic kidney disease. Cardiac diseases also occur. Valvular abnormality, mitral valve collapse, aortic regurgitation, coronary aneurysm not infrequent, asymptomatic pericardial effusion seen in 35% and 50% of this being moderate to severe in size. So extrarenal manifestation, cerebral aneurysm, next hepatic duct cyst, and cardiac manifestation. What are the cardiac manifestation? Like mitral valve collapse, aortic regurgitation, okay. Next, coronary aneurysm may be there, and moderate to severe pericardial effusion. Other manifestation, colonic diverticula, abdominal pain may be mimicker, okay. Colonic diverticula, abdominal wall hernia in up to 45% of patient, okay. So colonic diverticula and abdominal hernia also may be there. Now treatment, there is no treatment of the symptoms because this is a disease, genetic disease. So until and unless the genes or proteins can be knocked out, the disease won't subside. So there is no definite treatment, but treatment of the symptoms, like treatment of the urinary tract infection, treatment of the stones, treatment of renal failure, control of hypertension with ACE inhibitor, angiotensin converting enzyme, right? Due to increases renin angiotensin system overactivity due to rupture of cyst or ischemia around cyst, okay, due to cyst expansion. Angiotensin converting enzyme এর নাম কি বল একটা দেখি শুনি, হ্যাঁ, ক্যাপটোপ্রিল, আর আরেকটা কি দেয়, এনালাপ্রিল আর র্যামিপ্রিল, তাই তো। মোস্ট কমন সাইড এফেক্ট কি? Dry cough, very good. Nephrectomy is sometimes necessary for transplant, recurrent UTI, renal cell carcinoma and chronic pain, chronic hematuria. So until and unless the kidney are being transplanted with suitable donor, from suitable donor with HLA, proper HLA matching, there is no definitive treatment. All the treatment are symptomatic. Next is ARPKD. So ADPKD is autosomal dominant polycystic kidney disease. Next, ARPKD means autosomal recessive polycystic kidney disease. So the pattern of inheritance is recessive. So a diseased individual have their normal parents, okay. As this is recessive, they have normal parents, but they may have diseased sibling due to recessive pattern of inheritance. So estimated incidence is drastically lower than that of autosomal dominant polycystic kidney disease, 1 in 10,000 to 40,000. তোরা ওখানটা বসেছিস কেন, এখানে ফাঁকা কেন, কি আছে এখানে? সিস্ট, হ্যাঁ, হাওয়া পাচ্ছ না, ওখানটা গরম, এখানটা গিয়ে পড়ালে ওকে ক্যামেরা ঘোরাতে হয়, ঠিক আছে। Generally diagnosed in pediatric age group, okay. Causes diagnosed in adulthood have mild renal impairment but more hepatic dysfunction. So in contrast with autosomal dominant polycystic kidney diseases, autosomal recessive polycystic kidney disease, এই কি কথা বলছিস ওখানে, কি আছে ওখানে আমাকে বল, এখানে বস, গরমে বসবি, ওখানে আর কথা বলিস না। Then generally diagnosed in pediatric age, but in contrast kidney symptoms are less than that of hepatic symptoms, okay. Mild renal impairment but more hepatic dysfunction, and PKHD1 genes encodes in ADPKD, the genes name are polycystin 1 and polycystin 2. In ARPKD, that is autosomal recessive polycystic kidney disease, the gene, the defective, the faulty gene name is fibrocystin, okay. a cilial protein of cortical and medullary collecting duct and hepatic bile duct. So fibrocystin is a gene that encodes the cilial protein. Cilia means the movement of secretion, okay, the movement of cell. Cilia protein of cortical and medullary collecting duct and hepatic bile duct. So these are diagnosed in pediatric age group, and the problems with liver are more than problem of kidney. In ARPKD, autosomal recessive polycystic kidney disease. Kidney enlarged due to microcyst. What are the microcysts? That the cyst less than 3 mm. Liver always has hepatic fibrosis, portal hypertension, ascites and esophageal varices. So more dreadful outcome is atal recessive polycystic kidney disease. Autosomal dominant polycystic kidney disease have mild outcome, have undiagnosed or unnoticed at the age of 40, but autosomal recessive polycystic kidney disease, that is ARPKD, that has more dreadful prognosis or more grave prognosis, okay? And because of involvement of the liver in terms of hepatic fibrosis, portal hypertension, ascites and esophageal varices, okay? Diagnostic criteria is imaging, ultrasonography plus one of the following: absence of cyst in parents. This is a recessive inheritance, so parents will be normal, but sibling with disease and evidence of hepatic fibrosis. So presence of hepatic fibrosis, portal hypertension, esophageal varices, hepatic duct cyst, bile duct cyst are more important diagnostic criteria for ARPKD, autosomal recessive polycystic kidney disease, and it occurs due to defect of which gene? PKHD1, and the name of protein? Fibrocystin, ciliary protein. Okay, এগুলো MCQ আছে ঘরে এগুলো। কিডনি, দু সাইডের কিডনি, স্মল সিস্ট, মাইক্রোসিস্ট, এখানে তো ভালো বোঝা যাচ্ছে না এই ছবিটায়। এটা কি এগুলো? কোলনিক গ্যাস। এটা কিডনি। আগের ছবিটা দেখেছিলিস? লিভারের ছবিটা দেখিয়েছিলাম, দেখ। এটা হচ্ছে লিভারের প্লেনে কেটেছে এই ছবিটা। There is no gaps and laden with multiple innumerous cysts. কিন্তু এটা কিডনি, মাঝখানে গ্যাপ আছে। গ্যাপটা বুঝতে পারছিস তো? ঠিক আছে? লিভারের সময় ভার্টিব্রাটা দেখ কিরকম ছিল, ডর্সাল ভার্টিব্রা। কিন্তু কিডনির সময় ভার্টিব্রাটা কেমন আছে? লাম্বার ভার্টিব্রা। ঠিক আছে? So kidney has contained microcyst less than 3 mm. Next is nephrophthisis, small contracted kidney. Due to it is an autosomal recessive heterogeneous disorder affecting proteins in cilia. So nephrophthisis is autosomal recessive. Characteristic finding: reducing urinary concentrating ability, chronic tubulointerstitial nephritis resulting in ESRD by age of 20. So end stage renal disease and progressive renal failure. Onset is very early at the age of 20, that is the second decade of life. Commonest extrarenal manifestation is retinitis pigmentosa and it is present in 20% of patients. So nephrophthisis is a autosomal recessive disease and heterogeneous disorder affecting also proteins in cilia. Fibrocystin also a defect in ciliary protein, okay? And nephrophthisis is also heterogeneous disorder affecting proteins in cilia. Manifestation ki hoy? Present as polyuria, polydipsia due to impaired concentration of urine. So the concentrating ability of the thick ascending loop of Henle and the collecting duct has been impaired, okay? So the patient presents with polyuria and polydipsia, hepatic fibrosis and situs inversus. Situs inversus কি? সব উল্টে গেছে, তাই তো? ডান দিকে যা থাকার কথা বাদিকে, বাদিকে যা থাকার কথা ডান দিকে। তাহলে সাইটাস ইনভার্সাস থাকতে পারে আর হেপাটিক ফাইব্রোসিস ইনভ্যারিয়েবলি প্রেজেন্ট। তাহলে দেখ, যেই ডিজিজগুলোতে হেপাটিক ফাইব্রোসিস হচ্ছে সেই ডিজিজগুলোতে আউটকাম অনেক ডেঞ্জার হচ্ছে, প্রগনোসিস অনেক গ্রেভ হচ্ছে। অটোসোমাল রিসেসিভ পলিসিস্টিক কিডনি ডিজিজ হেপাটিক ডিজিজ ছিল, তাই জন্য হেপাটিক ফাইব্রোসিস ছিল, তাই জন্য এজ অফ অনসেট অফ সিমটমস, এজ অফ অনসেট অফ ইএসআরডি লেস ছিল, কম ছিল। এইখানেও হেপাটিক ফাইব্রোসিস আছে, তাহলে এইখানেও ইএসআরডি বা এন্ড স্টেজ রেনাল ডিজিজ at the age of 20. Okay, so nephrophthisis. So diagnosis is polyuria with bland urinary analysis. So there is no protein excretion, there is no blood excretion in urine, but there is the volume is more. Polyuria, that is more than 3 liter to 5 liter per day urine. So polyuria with bland urine analysis, progressive chronic kidney disease without hypertension and normal sized kidney, but in advanced stage the kidney sizes will be shrunken. If above 3 are present, genetic testing should be undertaken. If genetic test is negative, biopsy can be suggestive. So gold standard of diagnosis is biopsy. Like medullary cyst in normal sized kidney, another disease, medullary cyst in normal sized kidney, nephrophthisis er pore medullary cyst দেখেছিস, মাল্টিপল নাম্বার অফ সিস্ট, মেডুলা দেখ। So medullary cystic kidney disease, two type, MCKD1 and MCKD2, a rare disease with autosomal dominant disease, two types with invariable clinical courses, end stage renal disease at age 20 to 70. MCKD2 and MCKD1. MCKD2 is also called familial juvenile hyperuricemia. Okay, so একটু কথা কম বল, 5-10 মিনিট আর পড়াবো, তারপরে চলে যা, কথা বলিস না, গরম লাগছে আরো, শরীর খারাপ আমার। Describes family with mutation in the uromodulin gene. Uromodulin is a TAM Hertzsprung mucoprotein. Okay, pathophysiology, uromodulin is produced excessively in the thick ascending loops of kidney. It is a sticky insoluble protein which may assist in watertight integrity. So mutant protein cannot exit cell and cause tubular atrophy or death. আরে কথা বলিস না, আরো তো গরম লাগবে, 5 মিনিট চুপ কর, ভিডিও তুলছে, কথা বলতে ওদের ছবিগুলো তুলে পাঠিয়ে দাও তো প্রেসিডেন্টকে। কথা বলিস না, বেশিক্ষণ পড়াবো না, হয়ে গেছে। তাহলে MCKD1 medullary cystic kidney disease, defects of the gene is uromodulin, a TAM Hertzsprung protein, তাই তো। and clinical symptoms is hyperuricemia, gout, and progressive decline in renal function secondary to tubular death. আচ্ছা ডিজিজের নামগুলো খালি বল, শুনে নাই, ছেড়ে দে তোদের পড়াশোনা এখন। MCKD1 medullary cystic kidney disease 1, gene with chromosome 1, hypertension and hyperuricemia, no specific treatment, gold standard is biopsy. এই দেখ multicystic dysplastic kidney, এটা খুব ইম্পর্টেন্ট, শর্ট নোট আসে, congenital disease, only multiple variable number of cysts attached with connective tissue, no identifiable renal tissue, most important finding in antenatal screening. Antenatal screening যখন হয়, বাচ্চা পেটের মধ্যে থাকে, এইটা দেখে ডাক্তাররা, রেডিওলজিস্টরা, যে এই মাল্টিসিস্টিক ডিসপ্লাস্টিক কিডনি আছে কিনা। এটা যদি হয় তাহলে ওই পেশেন্ট বাঁচে না, কারণ যার রেনাল প্যারেনকাইমাই নেই, আইডেন্টিফাইড রেনাল টিস্যু নেই, তার এক্সক্রিশন কি করে হবে? এই দেখ ছবিটা, no identifiable renal tissue, only the number of cysts attached with connective tissue, very dangerous, বেশিরভাগ ক্ষেত্রে ইন ইউটেরো ডেথ হয়ে যায় পেশেন্টের। মেডুলারি স্পঞ্জ কিডনি, ম্যালফরমেশন অফ টার্মিনাল কালেক্টিং ডাক্ট, ছবিটা দেখ, ব্রাশ লাইক অ্যাপিয়ারেন্স ইন আইভিপি, আইভিপি মানে ইন্ট্রাভেনাস পাইলোগ্রাফি। কেন হয়? এই ওখানে কি আছে, গরম লাগছে, ওকে ঠান্ডা দিচ্ছে নাকি তো হাওয়া? ব্রাশ লাইক অ্যাপিয়ারেন্স, ঠিক আছে, ব্রাশ লাইক অ্যাপিয়ারেন্স কেন হয়? ডিউ টু ম্যালফরমেশন অফ কালেক্টিং ডাক্ট। এই যে কালেক্টিং ডাক্ট গুলো ম্যালফরমেশন, তাই জন্য যখন ডাক্ট ডাই দিচ্ছি ইন্ট্রাভেনাস পাইলোগ্রামে, এরকম ব্রাশ লাইক অ্যাপিয়ারেন্স হচ্ছে, ম্যালফরমেশন অফ দ্য কালেক্টিং ডাক্ট। বুঝতে পারছিস কি? আচ্ছা, এবার ওগুলো ছিল এক্সক্লুসিভলি সিস্টিক ডিজিজ অফ কিডনি। এবার কিছু সিস্টেমিক ডিজিজেস আছে যেখানে কিডনি সিস্ট থাকতে পারে, তার মধ্যে একটা হচ্ছে টিউবারাস স্ক্লেরোসিস, ওকে, হ্যামার্টিন 1, হ্যামার্টিন 2, TSC 1 and TSC 2, টিউবারিন জিন। এই দেখ, মাল্টিপল অ্যাঞ্জিওমায়োলাইপোমা, কিডনি সিস্ট। নেক্সট ইজ, বন্ধই হয়ে গেল। আরেকটা ডিজিজ আছে, এটা কি? ভন হিপ্পেল-লিন্ডাউ ডিজিজ, গ্লোমেরুলোসিস্টিক ডিজিজ। ভন হিপ্পেল-লিন্ডাউ ডিজিজে কি হয়? মাল্টিপল সিস্ট এন্ড রেনাল সেল কার্সিনোমা এন্ড হিম্যানজিওব্লাস্টোমা অফ আই এন্ড ব্রেন। গ্লোমেরুলোসিস্টিক ডিজিজ, এই দেখ ছবিটা দেখ, বায়োপসি, গ্রস পিকচার দেখ, মাল্টিপল সিস্ট ইন কর্টেক্স এন্ড মেডালা। আর বায়োপসি কি বলছে? এই যে মাল্টিপল সিস্ট হয়ে গেছে উইথ thin lining and dilatation of the lumen. Thank you. Sure.